provocative themes, and I'm very keen to actually exchange ideas and thoughts. I think nobody has the answers. I think the evidence is at best sketchy. I think we're all learning. There is change, and the change is really rapid, and I think we are dealing with a lot of uncertainty. And I have to say, the one thing before I start saying my slides, I've been hearing about what is the future of bariatric surgery, and I trained residents and senior registrars for many years, and I spent a lot of my time on the plane trying to train others. And people ask, is the specialty still going to exist? And people get very. Some of you may have been. Actually, I know I've met some of you in South America, in Santiago, for the IFSO meeting in Chile. And there's been a lot of shouting from surgeons saying, surgery has to survive. And I have to say that surgery may or may not survive, or bariatric surgery, if you like, but this is not going to be determined by how loud we are. And the advances in healthcare do not take employment rights into consideration. So if tomorrow morning we wake up and we all read a paper in the Lancet that shows that cancer has been cured, nobody will really worry about the employment of oncologists. And there's a lot of oncologists out there, and they will worry about it. And when we go to oncology meetings, and most of you and most of us do cancer surgery, training cancer surgery, every time there's a new development in cancer care, surgeons don't worry. Every time when immunotherapy became a thing, I didn't see anyone getting worried about immunotherapy. In fact, actually, this is great. We can actually get better outcomes for our patients. I often ask, I sort of prepare people for the FRCS exam, the exit exam for the fellowship of the Royal College of Surgeons of England. And I will say, what do you think is the biggest, and I want you to think of that question, what is the biggest advancement in care in esophagogastric cancer in the last 30 years? What do you think is the one study, in one clinical trial, one study that changed esophagogastric cancer in the last 30 years? And, occasionally people say robotic has made no difference in outcomes, really. It may improve outcomes a little bit, but, I've seen a big reduction in mortality in our audits here in the UK and globally. I think laparoscopy made a difference. I'm someone who spent a lot of my time developing minimal invasive esophagectomy and thoracoscopy and laparoscopy. But there's been, the impact of that in survival has been rather small. The biggest change was the MAGIC trial, giving perioperative chemotherapy to people, and that was a study that came out of the Royal Marsden Hospital in London, and we celebrate that. And I think we need to be careful. Why wouldn't we do that in obesity care? So I'll share some thoughts on exactly that. I'm just going to get my first slide up. And this is North Bristol NHS Trust, where I work, and South Mid. We took a picture on the one sunny day of the year. You're all welcome to visit at any time. These are my conflicts of interest, and you can see I work with a variety of organizations in the space of obesity, in the surgical industry, but also in endoscopy and pharmacotherapy, because I think we need a lot of different modalities for obesity and obesity care. We need to combine those modalities. And the fact, the most important conflict of interest I have is I'm a full-time surgeon. I don't just do bariatric surgery, I also do major trauma surgery and upper GI surgery, and I see obesity outside the obesity clinic. But perhaps what I should declare to all of you for this, particularly for this talk, is that I did my PhD 18 years ago on an obscure molecule called GLP-1, glucagon-like peptide 1. And nobody knew about this back in sort of 2007, and now I read about it in the national news every day. And, everyone really knows about what GLP-1 is. And I was one of the first people in the world that demonstrated that GLP-1 goes up after gastric bypass surgery. And that's the reason why we have a control of appetite. And that's the reason we have an improvement in glycemic control. And that's what we're trying to do. We're trying to understand how the operation works so we can replicate some of those effects with different mechanisms, and particularly with pharmacotherapy. And, we actually, if you'd asked me in 2007, if I thought that I looked at a lot of different molecules, a lot of different gut hormones. I work in Hammersmith, and my supervisor was Sir Steve Bloom, who discovered a lot of those molecules. We thought actually other molecules would be better than GLP-1, but that was the one that we could replicate pharmacologically, and I take some responsibility for the change that we see in obesity care today. I think it's a positive change, and I'll get some more detail about that. And the first thing to remember in bariatric surgery is that it's very safe. And the way I talk about this is by talking about cholecystectomy. So I just want you to think and tell me, what is the rate of death you quote for a cholecystectomy? Do you ever quote that? Do you ever tell anyone they may die from a cholecystectomy? Most of you will be doing this kind of operations. I do them. And I can tell you in my hospital, nobody ever gets told they may die from a cholecystectomy. But if you look at the 30-day mortality, not in clinical trials, but in real life data, and we have national audits, and this is an audit that our residents did about a decade ago, 8,900 patients, a few of them as an emergency. The 30-day complication rate is 7%, 7.1%, and the 30-day mortality is 0.15%. So it's very unlikely to die from a cholecystectomy, but the mortality is not zero. Now I want you to think, what do you think is the risk of dying from bariatric surgery in the first 30 days after surgery in the same period? And I'm going to give you UK data, but you can probably have your own view from your own audits. And I can tell you that in the same hospital, that we never tell people they may die from a cholecystectomy. We tell everyone, we write this in the consent form, and I appreciate paperwork is a little bit different in where I work compared to where most of you work. But we do mention death quite heavily. The actual death, sort of the mortality rate, is 5 times lower. So in the same year, again, we're using data from the National Bariatric Surgery Registry. Every operation in the UK gets registered there. We can actually check with hospital records what happens. It's 5 times safer to have a sleeve gastrectomy or a roux-en-y gastric bypass. At the time, most of the operations were roux-en-y gastric bypasses than have a cholecystectomy. So we're in a very safe space, and it's important to highlight that, which also means that there is space for us to do more difficult operations, because I think that if everyone's going to be getting medications, and I can tell you the numbers in the UK, we have 2.5 million people taking those drugs. We have 3.5 million people who qualify for surgery. We do 4,500 operations, so less than 1 in 1,000. We do another 4,500 operations in the private sector, and we send about 18,000 people every year as bariatric tourists, mainly in Turkey. So you can see that the numbers are very low, but if we're going to give people a lot of medications, about 10% cannot tolerate that. Another 25% will not meet the weight loss target, or they won't have the effect that they would like. We will need to do operations in people who will be sicker, who will be more complex, and they won't be the BMI 36, patient with very little obesity associated disease. There will be my typical NHS patient, which is a BMI of 64, often in a wheelchair, with sleep apnea, with type 2 diabetes, with some heart failure. And that shows that if the operation is so safe, we can't take a little bit more risk. The second concept I want to demonstrate is the variation and the heterogeneity in outcome. Bariatric surgery is the only type of treatment I know when everyone expects a mechanical effect. Everyone expects to have average weight loss, whatever you quote, 25, 30% total body weight loss, after gastric bypass. If you meet it, you're a good person. If you don't meet that, you need to try harder. And that's just not true. That's just not biological, but it makes no biological sense. This is the largest series of roux-en-y gastric bypasses in the UK. This was in the southwest of England. There are people I operated on when I was a registrar more than 15 years ago. And you can see the block lines. Every operation, every patient is a line. High preoperative BMI of about 50, and again shows that we operate on people with a lot of complexity. At 10 years ago, BMI 38. But what's really important to know is some people do really well, and some people do really badly, and most people do average. And those people who do really well, they're not morally superior. They're not more motivated. They're no more intelligent. They don't have a specific color of the eyes. They just have different biology. In the same way that if you do exactly the same operation for cancer, and your 5-year survival will be, in the best hands, it will be about 50%. We're starting to achieve that. Those people who don't survive at 5 years, they just have poor biology. And we offer them compassion, and we offer them treatment, and we give them escape chemotherapy, and we try to get the best possible outcomes from them. We don't tell them to try harder. We do this for obesity all the time. And if you look at the first time the term multimodal treatment for obesity and diabetes was used, it was exactly a decade ago. It was in September 2015. I wrote an editorial at the time at The Lancet, because we looked at the data from one of the biggest randomized clinical trials at the time, from Dimitri Pournaras and Francesco Rubino, A lot of you will be familiar with this study. It was performed in Rome, in Italy. Wrong wide gastric bypass, biliary diversion, and medical treatment for people with type 2 diabetes. And you can see that this is a randomized clinical trial in the best journal in the world by the enthusiasts in this field. They couldn't put a single patient into remission of the type 2 diabetes if you use the ADA definition. But they demonstrated a reduction of cardiovascular risk. That was, they didn't have power to detect a survival benefit, and the numbers are too small and the follow-up is too short, but they did make a difference. And that's the point Kyle Laroon and myself want to make at the time. And that's the first time with multimodal treatment for obesity and type 2 diabetes was used. If you do have a reference that has used that terminology before that, please let me know, because I am looking for it. And if you look at, again, the concept of the biological response to any treatment, that's the same for any type of treatment. If you look at diet, and I'm using an example here, this is low carbohydrate. You can use a different diet. What you see is a bell-shaped curve. Some people do well, some people do badly. Our ability to predict who does well is worse than a coin. We don't get it. We don't even get it 50% right. We have absolutely no way of predicting who's going to do well. The same thing with drugs, and this is liraglutide. This is the previous generation of GLP-1 receptor agonists. And if you look at semaglutide and tirzepatide, you'll see that the curve moves and shifts towards your screen right, but it's still a curve. And some people don't do well, and some people even have weight gain whilst being on the medication in a clinical trial, demonstrating that there's biological variability. And this is an endoscopic device, which is, again, is currently being revived, but hasn't been used for a few years. It has lost its CE mark for many years. It can all be used in the European Union. And we're seeing the new, yet again, another type of device or another type of endoscopy. You're seeing that if you're getting a good outcome, you're shifting the curve to the right, but you always have a bell-shaped curve, and this is, of course, gastric bypass. And it does make complete sense, because every biological phenomenon has this normal distribution of Gauss. So what we need to do is we need to see how we can get everyone better by combining modalities. And I have to say, I say that as a native Greek speaker, and I know I'm going to talk to you today. I'm not going to use any Greek philosophers. So I thought I was going to stick to a French one. This is Andrew Zid, who said that everything's already been said, but since nobody was listening, we have to start again. So I'm going to talk to you about concepts that you've all heard before, but perhaps we all forget, and then we have to do it again. And I'm going to talk again about doing it like the oncologist. How can we actually combine those modalities? And remember, right now, our data is very limited, and I'm not going to show you a lot of studies because there are not a lot of studies, but I'm just going to talk to you about the concepts. So first of all, we have to be very clear about what our intention is. So if you start someone on medication so they don't work and then you do surgery, or, we need to be clear, are we giving this medication so we can get them better? Are we doing a trial of treatment to see where they will land? And, you take some of the BMR of 40, and if they go to 30, you're happy. Are you taking some of the BMR of 60 or 70 to 60 so that you can actually operate on them? And I think that needs to be very clear, and that's exactly what the oncologists do. They don't give medications or chemotherapy or radiotherapy. They have a very clear rationale and intent. So if we're doing this for preoperative weight reduction, so that you can make surgery safer, which is particularly important if you're doing really marginal cases and really high risk, the people that come in with triple digit in the BMI, they come to my clinic, the BMI of 100 and 95, preoperative weight reduction, that's neoadjuvant treatment. I want to make those people operable, because right now their risk is too high. If I'm using this for, and we need to change that, I have to say, actually, I've just realized that weight regain is a term we should not be using. The IFSA now suggest that we use recurrent weight gain, and that's much more accurate. So people have recurrent weight gain. That's the same as rescue chemotherapy. So people who've had good treatment, they had a good response, but now the cancer has returned and they have a recurrence, we give them rescue chemotherapy. And that's the same thing if they're getting obesity-associated diseases such as type 2 diabetes. But how about adjuvant treatment? If we do this from the start, we say that we'll be giving surgery and pharmacotherapy to get the best possible outcomes. An example that I always use is breast cancer. We give hormone therapy to all women, if they qualify. And, again, we've done the clinical trials and we know exactly when we should be doing that. But we don't wait for the cancer to recur to give the hormonal treatment. We start this very early on. And we can do this with surgery. And of course, how do you do that with surgery? And again, there's big debates. Do you wait to see the effect of surgery? Do you wait for a few months or a year to see the effect of surgery and then add medication? That may be useful, and it's definitely intellectually interesting. Is this the right thing to do? I don't know. We need the clinical trials. Or do you give it from the beginning? And again, you need to be careful in terms of some of those medications may have combined side effects. Nausea is a dominant feature. Would you give this as early as I don't know, day 22? I wouldn't. I do this. I do give this medications to people who started with the medication. They want to continue afterwards, but I give them a break, make sure they recover from surgery, start to see the effect of surgery, and then I adjust the dose accordingly. I don't have the clinical trial data for that yet, but what we do know, and we have very good clinical trial data, is that medications work post surgery as well as working people who never had surgery. So surgery naive people and people who've had a sleeve gastrectomy, a gastric bypass, or what have you, if you give them medication, if you give them a GLP-1 receptor agonist, the effect is very good. And we've seen that from studies in people with type 2 diabetes. That was the Gravitas clinical trial. And we've seen this in people without diabetes as well. It does work. The next thing we need to do is we need to ask for clinical trials with uncompromising high quality of all modalities. And again, we do this with cancer. You can't be doing esophagectomy today with an, I don't know, open abdomen, open chest and give the latest chemotherapy. And equally, you can't be doing a robotic esophagectomy, but give chemotherapy from 20 years ago. And the same has to happen in bariatric surgery. We should be giving cutting edge pharmacotherapy. So second generation, even the next generations of pharmacotherapy that are coming. There's a lot of more drugs that are coming with multiple agonists, about a couple of hundred molecules in development right now by different pharmaceutical companies. And we need to be doing surgery that is really safe, high quality. We cannot be doing, for example, I don't know, historical operations or open surgery. So we need to combine high quality modalities to get clinical trials that are meaningful. And we have to do the work. So what we do at the moment is we keep modeling. So we keep doing models. Well, we have some data on surgery, we have some data on medications, and you do some models. We need to measure. We need to move away from modeling and go to measurement. And we need to do the hard work of actually doing the clinical trials. And of course, it's difficult to do them because these things are shifting too quickly. And if you do a clinical trial today with the medication that's available today, by the time you report the study, you'll have a new generation of medication. But we need some of the conceptual randomized controlled trials to happen so we can start informing our practice, as opposed to keep debating on a Wednesday evening about what the possibilities are. Having told you how to do it like oncologists, I'm going to tell you how to do it like obesity experts. And if any of you had discovered last night a new molecule that you think is going to be the cure for obesity, what used to happen is we would start by using this in diabetes. And I hear this very often. The GLP-1 was a molecule designed for type 2 diabetes, well discovered and then used as a target for diabetes care. And then accidentally, we found out that it has an effect on appetite. And I can categorically tell you that this is completely non-true. You read about this, or even read in the scientific literature, forget about the national and international press. That's not true. We knew that GLP-1 affects appetite. We knew this in the Hammersmith from the 1980s. We've seen those papers that came out of the Hammersmith in London back then. What happened was that industry knew that obesity is not a disease. It was definitely not treated as such. And of course, I disagree with that. I know obesity is a disease, but it was not treated as such. And then it was a good way of de-risking that by treating it, by doing the studies in people with type 2 diabetes. So we do know, and I'll show you this data earlier on, that complete remission at 5 years, is not very good. But what's fascinating is that you got very good glycemic control. So everyone had very good A1C. But if you look at the data at the time, you'll see that a lot of those people were not, a lot of people on the surgical groups were not on any medication. So if you start giving those medications to people with type 2 diabetes and the surgery, you're going to get extremely good glycemic control. And then you can talk even about the concept of remission of obesity. If you give surgery and drugs, to people with a BMI of 40, can you actually normalize the BMI? Can you push the boundaries to get really good outcomes, on people? And of course, what is the price tag of that? As those medications, wherever you are around the world, they're not cheap. They're very expensive, but they will get cheaper as they always do. And of course, a lot of us remember the era of statins. Statins were expensive. Now, we we're going to put statins in the water, I think, in the UK. When I started as a resident doctor in the NHS in the UK, the only way to prescribe esomeprazole, which is known as Nexium, was to get a signature from 2 gastroenterologists in the whole hospital. You have to find them, and they had to approve the drug. And now you can get Nexium in petrol stations in the UK. You know, it's completely an unregulated drug. You walk to any supermarket, you walk to any petrol station, you can find Nexium within 20 years. So things will change, and those medications will become more and more available. And I showed you, this is the standard 2 trial. This is another trial on type 2 diabetes, which again changed everything. And this trial is getting old now. This is 2008. And Peter Gede from Copenhagen, what they did is that they just gave, this is the reason that we give people with type 2 diabetes all the drugs at the same time. You have ACE inhibitors and aspirins and statins immediately. You don't wait for the complications. You don't wait for hypertension to get really high. You chase those lipids very early on at very tight targets, and they've demonstrated, and they take people with quite a lot of high risk. They had a lot of renal impairment, but they were able to demonstrate mortality. So what you can see, the difference of those 2 lines is the cumulative incidence of death. So they saved lives with just a little bit more than decades of using very, even back then, even 2008, those medications were cheap, they were available, and they made a big difference. And when you think about how we're going to do that in obesity care. And this is the data I showed you early on from, that I spoke to you about early on from the Italian study. And you can see that the surgical groups, wrong Y gastric bypass, bilipancreatic diversion, the gray is no treatment. And you can see that those surgical groups are getting no treatment. They're getting equivalent outcomes or better outcomes from medications. But imagine what would happen if we gave those people really good medications for the type 2 diabetes. We'll have even better outcomes that will impact on their survival and on the complication rate related to the type 2 diabetes. So this is one of the studies we're doing now. It's BariPlus. This is a randomized clinical trial we do in Bristol and in Dublin. And we're also involving Sao Paulo and Ricardo Cohen's unit, where we're doing exactly that. We're taking people with diabetes, we give them surgery, and we either do the standard medical care, which is wait and see what happens to the lipids, wait and see what happens to the diabetes, wait and see what happens to the hypertension, or we chase the International Diabetes Federation targets, and that's an A1C of less than 6.5, systolic of 130 and diastolic of 80, and an LDL of less than 2.6. And I appreciate these are different figures. I'm pretty certain in Greece we use different figures, but these are the standard sort of numbers for normal A1C, normal blood pressure, and normal LDL. So we're just chasing those targets. I'm going to start summarizing because I think it's really important to have more of a discussion. So I'm not going to show many slides today, but I hope I've convinced you today that it's all about multimodal treatment of obesity, and we need more than one option, and we need to celebrate the fact that we now have a lot of options. I often say that we as bariatric surgeons are like small children that have been, had all our Christmases together. We know everything we've been asking for from Santa. We want better care, we want more treatment, we now have all these amazing medications, but it's also happened too quickly and we don't know which present to open. And we're getting a little bit uncomfortable about the changes in our specialty, but we have to embrace those changes, and those changes are very fast. This is the Concorde, and this is the last time a Concorde ever flew. This is the last landing. It's just flying over Clifton Bridge. This is a couple of miles away from my hospital and from where I live, and it's just, you can see a lot of people. You can see a lot of people on the hills there on the Clifton Down, waving at the Concorde. And about 20 years ago, it just landed, and you can still visit. This is the last Concorde ever landed in history. It is in a museum in Bristol. And of course, the point I'm trying to make is, again, it was the speed of it. It was well ahead of its time, of course, and the world is a smaller place without a Concorde. But the pace of change is fast right now, but it will never be this slow again, because things will continue. The medications we have right now for obesity are amazing, but they're the worst medications we'll ever have. And it's important to recognize that the future looks bright. These are the people I work with in North Bristol and some of my collaborators in Bath, in Dublin, and in Sweden and elsewhere. And with that, I'm going to thank you for your attention, and I'm looking forward to the discussion.
Dr. Pournaras, thank you very much. It is probably the most inspiring talk I have heard the last years in my life. And I would like to open the discussion right now. Does anyone want to add something, ask something? Because I have a lot of questions in my paper here, but I don't want to start first. So please. Okay, I will start first. So I'd like to ask, is there any RCTs right now, or do we have evidence on how the combination of this medication and surgery works?
Yeah, so if you take biological, if you fight from biological sort of basis, you think that this surgery increases GLP-1 dramatically. I didn't show you any data today. I've showed a lot of this data in the years before. It just makes me feel very old because the sort of work I did 20 years ago, GLP-1 goes sky high. So when people were doing, and one of the study that really changed our thinking is Gravitas. They took people up with type 2 diabetes at the nadir of the weight, and they gave them liraglutide for the diabetes, and they saw that A1C improved, and they saw that there was weight loss. And the chief investigator of this study was from Imperial College, as Alex Miras, who's also a fellow Greek, who I've met in London. I mean, you know, you have to go very far sometimes to meet other Greeks. You know, India is far, but you know, London was also far. So Alex Miras did this clinical trial, and you know, I remember telling him that you're wasting your time, Alex. I mean, you know, this is going to be a negative study. I mean, why would more GLP-1 make any difference? And of course, we're completely wrong. And the opposite happened. So we saw very good weight loss. And the way to understand that is to remember a little bit again, and I don't have data for that, but that's what makes sense, is that your endogenous GLP-1 only lasts for minutes. So it's about 8 o'clock in 8:35 in Greece. A lot of you will have dinner very soon. You'll stop eating when you feel full. And that's when GLP-1 goes sky high. But the half-life of that is very short. It's only a few minutes. So I think when we give medications, those last for longer. And the reason if you ask me, what's the historical day that changed obesity care? You know, what's the one study on medications that did it? I would say it's 2021 when semaglutide, you know, reported a 15% weight loss. I think that even the company was not expecting that. Semaglutide was the next generation of liraglutide. Liraglutide was once a day injection. I'm not sure if it was available in Greece, but it was once a day injection for diabetes and obesity, 7% weight loss. I don't remember any bariatric surgeon worrying about liraglutide. Okay, 2021, once a week injection. That's why they developed it. The weight loss goes 15-16%. So now that's really impactful. And I think the reason for that increase is because your half-life of the molecule is now many days. And I think it probably has more central effects in the hypothalamus. That, you know, you can't cross the blood-brain barrier if your half-life is 3 minutes. So that's why I think we see that. So this is speculative, what I'm telling you, and I know I'm giving you a long answer, but it's a really difficult question. What's the mechanism? We don't know, but it's a good assumption that the pharmacological increase of GLP-1 keeps the molecule in the bloodstream for days, and it probably has more central effects in our appetite control, and that's why we see those effects after surgery. Does that answer your question?
Yes, partially, but we still don't have trials checking the actual effect. I mean, on weight loss. Do we have?
We do have. So we have BariOptimized and Gravitas. These are the two clinical trials, and I'm very happy to share them actually with the group. So they would, you know, in type 2 diabetes and in people with. So this is for medications after the weight loss. What we don't have is adjuvant pharmacotherapy trials. So we start the medications at, I don't know, day 90 after surgery. We don't have any of those, but we have studies where we've taken people who've had a suboptimal weight loss for whatever reason, and then we give them the drug and it works. So we know it's safe and we know it's effective. Mm-hmm. And that's for rescue pharmacotherapy, but we don't have it for adjuvant pharmacotherapy. And I said, you know, that's the sort of the clinical trial we need to do. It's a difficult one, but that's what we need to do.
Okay, that answers my question, yes. And I also would like to ask, do you have evidence?
Professor Skroubis wants to ask something.
Excuse me.
No,
You can continue, Gina, of course. I'm
Sorry,
waiting.
one question more.
No.
Do you have evidence? This is something that we discussed in the beginning, the three of us. Do you have evidence globally or nationally on how this medication affected the surgical practice of bariatric surgery?
I think that anyone who says that they have medications available in the community and their bariatric surgical practice has not been affected is lying or is living on another planet. I think that we do know that we will be affected, just like, this is a big advancement, and depends on the penetration of the medications in your country, and a lot of it has to do with its price. So in the UK, we know, so the government thinks it's 1.5 million people, and we have a lot bigger population, 1.5 million people on the drugs. The companies tell me it's 2.5 million. It's probably somewhere there. So that's a lot of people on these medications. What's important to remember is that outside clinical trials, the rate of stopping those medications at 12 months is extremely high, and that's multifactorial. And that's because they're expensive. Side effects is only a small part of it, but the main thing is that they're expensive, and a lot of governments and insurance providers do not cover for those medications. It's also important to recognize that this is not a good thing for obesity care. So we as surgeons need to advocate for these medications to be lifelong. You wouldn't give insulin for 6 months. You wouldn't give an antihypertensive for 12 months. You wouldn't start someone on thyroxine and only fund it for 2 years. That's ludicrous. And we do this for obesity. So we treat a chronic condition, a chronic and recurrent disease, we treat it as a fracture. And that's nonsense. We have to challenge that. But the reality of it is a lot of people will stop those medications. So the drops that we'll see depends in which part of the world you are, and particularly in completely commercial sort of healthcare systems. So if you take away government and insurance healthcare systems, I think you're looking into 60-80%, in many parts of the world. Is this how it's going to be? No, I think it's going to go down and it's going to go up. We need everyone to be on the drugs. And then, so if you take, for example, 2.5 million people in the UK, that's 10%, 250,000 people cannot tolerate the drug. But now they've been exposed to appetite control. They know how it feels to have a switch off button in your brain and actually not feel hungry all the time. Now, a lot of those people will ask for surgery. 250,000 people. Just remember that we do 4,500 operations in the National Health Service. So you can see that if you ask me, what is the bariatric surgery market, if you like, of patients, it is going to increase massively, and we're only starting to see that increase. If you ask me, what is my biggest worry about bariatric surgeons in the next 5 years, is I think we're going to have to work very hard. I think we're going to find it very difficult to meet on Wednesday evenings because we're going to be operating all the time. And by the way, cancel all your holidays. That's my worry, not about bariatric surgery not existing. But is that a given because I say so? Absolutely not. Can we mess this up? Yes, if we keep rubbishing the drugs and say they are terrible. We are people who increase people's GLP-1. That's what we do for a living. So if we're going to tell people that GLP-1 is a really bad molecule for you, we're losing credibility. So it's important that we embrace change. And if you had a cancer surgeon who's rubbishing immunotherapy and chemotherapy, would you trust them? I wouldn't. So we need to be those people that are honest, transparent, and actually embracing changing as opposed to constantly fighting it.
Professor Skroubis?
Firstly, I want to congratulate Dimitris for a brilliant, presentation. I'm, as you, optimistic about the evolution of obesity medications. Take this as a message. After the evolution of obesity medications for the whole planet, obesity now is a disease. Because as you know, the patients, even the doctors, when you have a medication, you have a disease. They don't believe that obesity is a disease. Nowadays, that's one of the advantages after the evolution of obesity medications, I think. And as a target, because as a surgeon, I'm a realist, I think that until now, only 1% of the patients that they are eligible for a bariatric operation, they are operated worldwide. So if we just increase for 1% this 1% of the patients that can offer them surgery operation, then we have so many bariatric operations in the future. And I agree with you that we have to work harder and educate new generation of bariatric surgeons for this kind of surgery. But on the other hand, I want to ask you one question about side effects of medications. Although I'm not happy that the problems with our patients, they are named as complications, and the problems with the medication are named side effects. Do you have any data from the UK about the side effects of these new drugs?
Absolutely. So first of all, George, I have to say that I'm in complete agreement. I'm not a naturally optimistic person. I live in a country that always rains, and I'm renowned for saying to all residents that if you're doing GI surgery, any type of gastrointestinal surgery, and you're still an optimist, you haven't been in this game for long enough. You know, things will go wrong, and they always go wrong. And I'm generally surprised when things don't go wrong. So I'm just like you, a pragmatist about this, and I think that the future looks good because absolutely, as you say, the enemy, if you like, of a bariatric surgeon today is not the drugs, it's the lack of treatment. As soon as you have good treatment, there will be a lot of surgery, there will be a lot of medications, there will be a lot of endoscopy, there will be a lot of everything. So I completely agree with you. In terms of side effects, I think it's appropriate. So all regulators around the world, you know, they call, and I have to say, I do sit in front of the FDA, I do advise NICE, you know, in the UK, and I do get into the regulation of all those things. It is side effects because you can stop the side effects. So, you know, you stop the drug, the side effect goes away. In surgery, you know, you have a complication, it doesn't go away because you stopped it. So it is fair to be different about that. Now, in terms of the side effects, we do know that nausea is dominant, and I think again, we as surgeons, we should be telling the world on how to look after people with medications. So we know first of all what the side effects are. It's nausea because it's the same spectrum of appetite. So if you're really hungry, you feel sick, and if you eat, you know, you start feeling full, eventually you feel full. If you continue to eat, you start feeling sick again. And that spectrum is shifted with medications, so nausea is common. The very common error that prescribers of these medications do, and again, you have to ask yourself if you want to prescribe this or not. I have to admit that I've been prescribing these medications for many years, is that people increase the doses too quickly. So you got to go really slow. So my practice is that I start the doses of any of those medications. I have access to Wegovy and I have access to Mounjaro, and I used to have access to Ozempic. You know, when I first started prescribing those drugs in Ireland, in the Republic of Ireland, many years ago, I started the lowest dose, and I never increase it if you feel sick. So the patient has to have no symptoms until I increase them. So that's the main thing. Then you have the weird and wonderful things. So pancreatitis is becoming something that we all study. It's most likely due to gallstones. And again, we're getting more data on that. Delayed gastric emptying is common. So the American Society of Anesthesiologists has some really strong guidance on stopping the drug for like a month or two. In typical American fashion, you know, they have made no difference between the liraglutide that has a half-life of, you know, 12 hours and semaglutide that has a half-life of 4 days. So there is some UK guidance, and I'm very happy to share that because I happen to be one of the authors, which is a lot more pragmatic about when you stop medications before a general anesthetic. So again, we'll see quite a lot of that. But it is about pragmatism. It's about shared decision-making. You know, if you have someone who's on these drugs for heart failure, you know, then you need to be a little bit more careful. And if someone is on these drugs because you know, they have a big family event and they want to look better, then you can tolerate stopping this drug for longer. So I'm very happy to share that. But we know we don't see big disasters. We will see nausea, we will see side effects, but most of those side effects are not dangerous. Pancreatitis is probably one of the dangerous things. Aspiration pneumonia is one of those things. Remember that even overdosage of these medications is not, it won't give you hypoglycemia. And again, because as bariatric surgeons know the biology, GLP-1 only works when you have glucose in your gut. So, you can't overdo it. It doesn't have the same risk as insulin. You give me too much insulin, you'll kill me pretty quickly. But with GLP-1, it's a lot safer. So overall, what I wanted to take from all this is really safe. There are side effects like in every drug. And most of the response to the side effects is because we don't think that obesity is a disease. The side effects are well balanced towards the benefit. In fact, it's really favorable to take those drugs and reduce the side effects.
Thank you very much, Dimitri.
Thanasis, do you want to ask something?
Yes, I would like to stay in the realm of complications and side effects. And first of all, excellent talk. Very inspiring indeed. I liked very much the fact that you compared bariatric surgery to very common practice like cholecystectomy or cancer surgery. Last week, I attended another webinar, and I heard a very interesting statistic. If the safety profile of obesity, of cholecystectomy was the same as flight safety, there would be 20 plane crashes daily on a daily basis. So that's very intimidating. So what I want to ask, actually patients and sometimes even doctors who are not familiar with bariatric surgery compare drugs with surgery and say that if I am to have the same effect with surgery or drugs, I would definitely opt for drugs. How do you convince in your practice patients that you should opt for surgery if a patient is a candidate for surgery?
First of all, I'll say that I'm an aviation enthusiast and I spend too much time on planes, and we learn a lot from aviation. But I always say one thing, that if you look at the safety profile, and planes are really safe, we don't see planes falling off the sky. But if you look at the planes that have healthcare involved in them, so if you have the medical evacuations and if you add the transplant flights, their rate of fatalities increases exponentially. So as soon as you put healthcare, even the planes become unsafe. And we know why, because if you have a new liver or a new heart and you say, look, I'm running out of time, please go through the clouds, you will take risks. So it's important to recognize that aviation is very good, but healthcare is a lot more messy than the getting on a plane, and a lot more real. So in terms of answering the really important question, what do I tell my patients, is that, so I tell them the truth. And the truth is that we don't know which one is better. And if you have a good outcome, if you're going to respond well to medications, then you're better off with medications. Fact. If you need to lose 15% of your weight, I ask him, what do you want to do? So my first question, so if you actually, I'm going to operationalize this, what do I do? Patient comes to clinic, first thing I tell them, obesity is a disease. It's like any other disease. It's not your fault. Now I'm going to ask you, what do you want to get out of it? And I really push them. So I don't have any patient that comes to me and says, I really want to reduce my cardiovascular risk, or I want to reduce my A1C. People say, I live in the UK, so people say I want to ride a horse, or I want to be able to play with my grandchildren, or I want to make sure I don't get diabetes. And then we make a shared decision process of understanding what weight do you need for that. Because you can improve your cardiovascular risk with 10% weight loss. But if you want to be able to not have your sleep apnea, or if you actually even more, if you want to not sort of have pain in your knees, you usually need 15% weight loss, but you may be able to do that. But if you need 20, 25%, you need surgery. If you're okay with 15%, you're better off with medications. But what I do is, because I maintain the integrity of that discussion, I don't tell them rubbish. I tell them what the facts are. Then I say, look, let's start the drug, and let's see how you're going to be in 12 months' time. So let's see if you tolerate the drug. And let's see if and I keep the patient in my clinic, you see, or work with whoever looks after them. If I prescribe them personally, so if you can't tolerate the drug, straight for surgery. If you tolerate the drug, but you don't have a response, or a good enough response, back to surgery. But now you have that sort of transparency, and that relationship is valid. So if you tell that patient that's rubbish, you should have surgery, these medications, you're going to have taken for the rest of your life. It's a dangerous molecule that the pharmaceutical industries are trying to get into you. That patient goes away and says, well, but my sister got the drug and she's absolutely fine. And she lost 15% weight loss. They're never going to come back in your clinic. So I think it's important we maintain professionalism and honesty. And I think patients will stick with this. And it's a long game. Okay, it's not a game, it's a serious thing, but it's a long event. It's a marathon, it's not a sprint. So if you keep looking after patients, and if you're in private practice, that patient is probably going to get gallstones. Well, they're going to trust you to have, for you to take the gallbladder out. If you told them, things that were not sort of professionally or appropriate or scientifically accurate, they're not going to trust you with the gallbladder either. So you can see how this is a long process that requires transparency, honesty, and professionalism, just like we do for any other disease.
Very insightful. Thank you.
Yeah, perfect. And I also congratulate Dimitri for a very interesting and inspiring presentation. Congratulations, as usual, Dimitri does. And I can't agree more with you, Dimitri, that we have to be honest with our patients. I mean, it's very difficult in my practice to persuade somebody who really wants to have medication to go to surgery, even if he's if he's with a BMI of 60 or 55. If he still believes that he has to take medication, as you said, I explain to him everything, and I put him on medication. But I am honest. I explain him that's not the right way to go on. I think you're completely right. And if you are honest with your patient, then they will come back and ask you for the next step.
Completely.
Congratulations again, Dimitri. Excellent.
You're always very kind. But absolutely, I think what we do. Remember that even so, someone with a BMI of 60, we give them the drug. We're not doing something wrong. We think that surgery is superior, but for that individual patient, their risk-benefit balance at that stage is, for them, is favorable to have medications. We're not doing something dangerous. Okay.
Exactly.
So, I always say that, it's not, and if someone comes with a BMI of 38 and they want to have surgery and they don't want to have medications for whatever reason, that's also okay. It's not like we're doing an esophagectomy or someone with metastatic disease. It's not. People have both options, and we can service both options. And I think we as surgeons need to service both options and be guided by the patient. And as you say, these people will come back. They will come back. They will come back to us because they know that, and they may take time, but they will come back. I have no doubt.
Exactly. Thank you again.
Does anyone else want to ask something? Because I have one more question. Dr. Stralis, Dr. Albanopoulos. I don't hear Dr. Stralis. Do you?
No, but I think Dr. Stralis can find me all the time. I tend to meet him in conferences nowadays. I think he's asking me all the difficult questions. But I'm very happy to have another one, Ilya. Absolutely.
You have to.
I can't hear you, Ilya.
Yeah.
But, is there a text fashion? You can even text me. If you text me.
You can. I think there is a chat.
You can even text me on my mobile because I have it in front of me here, and I will only respond to Liz. I'm not going to check any other text messages. Feel free to text me.
If you want, there is a text box on your right hand.
Do you hear me now?
Yes.
Yeah.
Congratulations, Dimitri. I don't have any specific question. I think that in advance, in the future, we don't have to fear about medicines, and we don't have to feel like losers in front of medicines. This is just a weapon for about making our job more easy. That's it.
Yeah, I completely echo that, Ilya. Absolutely agreement.
Thank you.
One question. Are we going to find GLP-1 in petrol stations?
Yes. Yeah. And when that happens, we'll but we can bet on that. It won't be tomorrow. It will not be next week. And probably will not be in injectable form because of the logistics. But GLP-1 in tablet form, GLP-1 receptor agonist in tablet form, which is now, you know, a recent study was a positive one. You know, there's some good results. Remember, we had semaglutide in tablets, not powerful enough. I think tirzepatide or not tirzepatide, but GLP-1 and GIP will become powerful enough, and I think it will be around the 10% weight loss, maybe a little bit more. And I think that will eventually come to petrol stations. It will take years, so you know, it may take 10, 20 years, but it will happen. Just like statins.
Thank you. May I ask one more question?
Absolutely.
You said before that you prescribe this medication at your practice. So I was wondering, this, I don't know the surgeons that prescribe medication like GLP-1, because they are considered anti-diabetic medication, and we trust endocrinologists to do that. But do you know if this is legal or illegal or ethical or unethical for a surgeon to prescribe this medication? Because technically we're allowed to do so. We can buy them, but I don't know if this is legal for us. Let's say if a patient has a complication, is it okay for a surgeon to prescribe such drugs without an endocrinologist?
So I don't know the legal framework in Greece, and I don't want to misguide you, but I have no ethical concerns around it. We prescribe drugs all the time. You know, we prescribe omeprazole. It's no more dangerous than omeprazole. You know, for people with reflux, and gastroenterologists prescribe it, and we prescribe it. So I have no ethical concerns about it. It's a very safe drug. And also we understand obesity. And the framework I would suggest that we need to have is that a multidisciplinary team meeting. So I think that a bariatric surgeon working together with a dietitian and a psychologist, and often a physician, is in a much better position to prescribe these drugs than an endocrinologist on their own in their office. We actually have a lot more expertise, a lot more multidisciplinarity. I also think we need to think about what are the complications and side effects, as George said earlier on, you know, of this medication. What are the big problems? The big problems are the two spikes. The first one is around side effects when you start the medication, but most of them are down the line when you have actually lost 20% of your weight and 25% of your weight, and you have nutritional complications because, you know, if you're going to lose 20% of your weight, you're not going to get enough protein. You're not going to get enough micronutrients. And I think that the bariatric multidisciplinary team is best placed for that. The psychological complications of body dysmorphia, the fact that that amount of weight loss is such a life event. Again, where is the best place for these people to be looked after? A bariatric MDT, a bariatric surgery MDT. So I don't know the legalities, but I have zero ethical concerns about it. It's a safe drug. We prescribe a lot more dangerous drugs. We're very happy to be part of multidisciplinary teams that prescribe chemotherapy. When I was doing cancer, the mortality rate of chemotherapy was a lot higher than the mortality rate of esophagectomy in the esophageal cancer centers I worked in the UK. So more people die of chemotherapy than esophagectomy, and I suspect that's probably true in Greece as well. So you know, let's just give the drug and be safe, but know the legal framework. And you know, I'll give an example, Gina, because I used to prescribe Ozempic, which was not licensed for obesity, it was licensed for diabetes. So Ozempic is 1 milligram of semaglutide for diabetes. So here's the crazy thing. You were not allowed to, so when people got hold of it, they said, no, you can't prescribe Ozempic. The approved drug for obesity is semaglutide 2.4 milligrams, which is Wegovy, okay? So, and then my regulator, the General Medical Council, and for those of you who work in the UK know that you don't want to be upsetting the General Medical Council, said, if you prescribe Ozempic, you're breaking the law. Now, that's completely unreasonable, okay? So you're telling me that prescribing 1 milligram of semaglutide, I am breaking the law. But if I prescribe 2.4, I'm okay. Now, that's nonsense. But that's what the General Medical Council said. Would I go against the General Medical Council? No. So sometimes it's important to know I have no moral concern about all these people that gave 1 milligram of semaglutide when I was allowed. But would I do that today and break, you know, be sort of opposite my regulator. No. So know what your local regulatory framework is, but absolutely have no concern, no scientific, no professional, no clinical concern about surgeons who are well trained prescribing GLP-1 receptor agonist-based treatment.
It was a very good answer. But may I ask the audience, the Greek surgeons who are here, if they have any experience with prescribing this medication?
These days,
Only
even
through MDT.
gynecologists prescribe them. So
Excuse me, Thanasis, I
these
didn't
days,
hear.
even gynecologists can prescribe them. So there is no regulatory frame. I personally do have experience, and I offer all modality treatments to my patients. And the patients accept it pretty well. They know they come to a surgeon, and they know they have, beforehand, they know that I might suggest all kinds of options. And so far, I haven't had any issues.
To my knowledge, the only available medication for prescription in Greece is Ozempic. Am I wrong?
I don't prescribe. I mean,
You just suggest go
I
take.
suggest that I prescribe. First of all, I prescribe all the medications that are eligible for obesity. Ozempic, even in Greece, is eligible only for diabetes.
Mm.
So I prescribe either Wegovy or Saxenda, or Saxenda in the past, or Mounjaro.
Yeah. Okay. So no. Okay. I understand.
And of course,
I think
I follow them up.
yeah.
I mean, I do too.
Okay, I do the same thing because I'm working with Thanasis, but I think that what Dimitri said is the most important thing. I think the best place for these patients to have any kind of new anti-obesity medication is an MDT team. And that's the safest and the best place to have this medication.
Agree.
It's also great fun. So I can't prescribe them in my. So I have two. I have multiple jobs, but one of my job is my day job is working for the government, for the NHS. I can't prescribe them, but I do have a private practice. And actually, I used to have a private practice in the Republic of Ireland, in Dublin, and now I have one in Bristol. And the main reason I have this practice is to prescribe them because it's so much fun. You're taking people who have had this, really difficult disease, and you treat them with another modality. Or I have my patients who had, a gastric bypass, but they didn't have the response they wanted, and I can give them a drug and they get a good response. It's really rewarding. By fun, I mean rewarding. It's professionally and personally rewarding, giving people a good and safe treatment. And you need to be prepared to take the phone call, or have someone in your practice that takes the phone call and checks on them and make sure that they don't feel sick. But overall, I would urge you, for any of you who are thinking about this, if your legal framework around you allows, just do it. It's just so rewarding.
I think we could have this conversation going for long, but I'm sure that Dr. Pournaras has a lot to do, and we are very happy to have you here with us today. It was a pleasure, and it's always a pleasure to hear you speak. So I hope we have again the opportunity to have you again with us in another webinar, maybe, because there's a lot to explore on this field. And I want to thank everyone for being here so late in Greek time. I'm happy to see you all again after this weekend. We were in Patras. And stay tuned for the next webinar. It will be next month. You will be informed from social media about the topic and the date. Thanasis?
Thank you, Gina, and thank you, Dimitris. Καληνύχτα, φίλε.
Thank you for having me. Kalinichta. Thank you.
Thank you so much.
Καληνύχτα, Δημήτρη. Congratulations. Καληνύχτα.
Thank you.
Thank you.
Καληνύχτα σε όλους μας. Και
Καληνύχτα.
στη Θεσσαλονίκη και στην Πάτρα και παντού.
Παντού.
Είναι πολύ ωραίο που ήρθατε όλοι, που μαζευτήκαμε πάλι όλοι. Ελπίζω να σας άρεσε η ομιλία του κύριου Pournaras.
Ναι. Είχε όντως κάποιους... όχι, δεν βλέπω κάποιους...
Ναι.
Την ώρα που τον άκουσα να μιλάει στα αγγλικά, άρχισα να λέω ξέχασε να μιλάει ελληνικά ο Δημήτρης. Τι έγινε. Μπερδεύτηκα.
Η αλήθεια είναι ότι νομίζω το συζητήσαμε ποιο θα του ήταν πιο βολικό και είναι
Ναι, οκ, ναι, σίγουρα.
Ναι.
Καλό βράδυ σε όλους.
Καληνύχτα.
Καλό βράδυ.
Καλό βράδυ.
Καληνύχτα, παιδιά.
Θανάση, μπορείς?
Ναι.
Μπορείς να μιλήσουμε, να σε πάρω?
Ναι.
Ναι. Καληνύχτα, κύριε Λαπατσάνη, καληνύχτα, Παναγιώτη, καληνύχτα. Θέλεις... οκ.
Κλείνω, παίρνουμε τηλέφωνο.
Ναι, έλα. Καληνύχτα.